Hello, my name is Dr. Alex Lyon. I'm a consultant cardiologist at the Royal Brompton Hospital, and I hope you've enjoyed this symposium from Myocardial Solutions on this novel technology of MyoStrain. I've been reflecting on the symposium and really what are the key take-home messages. This is my conflict of interest. So I think we all recognize that cardiovascular toxicity is a growing problem and a real clinical challenge. This is in part due to the increasing prevalence of cancer in the world. So there are more patients. There's an increasing cardiovascular toxicity profile of the treatments being used to treat cancer patients, particularly many of the modern targeted designer treatments, as well as traditional cytotoxic chemotherapies such as anthracycline chemotherapy. And also, speaking to my oncology colleagues, cancer patients are frequently older now than they were previously, and many arrive at the cancer center with pre-existing cardiovascular disease. So their baseline risk is higher at the time they're being diagnosed. This is an opportunity for prevention. We know when they're coming to the oncology hospital and the clinic or the hematology clinic to receive these treatments. So at their diagnosis, there's the opportunity to perform a baseline risk assessment and thereby stratify patients into a low, a medium, or a high risk, and therefore personalize their monitoring and surveillance during their chemotherapy and their follow-up. And now we have more and more sensitive technologies to pick up cardiotoxicity early before a patient presents clinically with heart failure or other complications of their cancer therapy from a cardiac perspective. And in particular, the use of modern cardiac imaging and modern cardiac biomarkers during their treatment to pick up problems early, not just waiting for the left ventricular ejection fraction to fall. We've heard in this symposium that MyoStrain is a new cardiac MRI technology. It's a short scan, takes only 5 minutes, so there's the ability to perform this on many patients during a clinical session. The report comes back to the doctors quickly so we can make decisions in real time. This technology measures the left ventricular volumes, the wall thickness, and provides the left ventricular ejection fraction. But much more than that is this novel parameter called MyoStrain, which is a highly sensitive way of measuring the function of the heart in different segments and therefore a reflection of myocardial health. It has the advantages of MRI that it's radiation free, and for individuals who have poor echo windows, that is not a problem in this technology. It's currently limited to being recorded using Philips and United Health MRI scanners, so that is one current limitation, but hopefully in the future it will become compatible with a whole range of the MRI scanner vendors. So earlier this year, we published this cardiovascular risk assessment in collaboration between the Heart Failure Association of the European Society of Cardiology and the International Cardio-Oncology Society. And as you know, there's a range of baseline parameters and factors that contribute to calculating an individual's cardiovascular risk, including previous cardiovascular disease, risk factors such as their cholesterol and diabetes status, lifestyle risk factors such as smoking, and then the assessment of their heart function at baseline with cardiac biomarkers, an ECG and an echocardiogram, and of course their oncology history if they've already had cardiotoxic treatments such as prior anthracycline chemotherapy. And on the right, we've created these proformas for a range of cardiotoxic cancer therapies so that in the clinics, in the oncology clinic and the hematology clinic, individuals diagnosed with cancer can have their baseline risk calculated, and then they can be stratified into a low, a medium, or a high risk group. So where could MyoStrain fit in with this? Well, I think having a baseline assessment of myocardial health using MyoStrain, it's going to detect some individuals who would previously have considered a low risk, but actually already have some abnormal LV function. Conversely, if their MyoStrain at baseline is normal, that is very reassuring that they have a very healthy myocardium. And so this, I could see in the future being a parameter we add to this proforma. Then there's how we monitor patients during their treatment. So many patients with lymphoma will receive 6 cycles of anthracycline-containing chemotherapy, whether that's ABVD chemotherapy for Hodgkin's lymphoma or R-CHOP chemotherapy for diffuse large B-cell lymphoma. And again, earlier this year, we've published a surveillance protocol strategy, which is personalized to the baseline cardiovascular risk. So, but depending on whether an individual is low, medium, or high risk, the frequency of their assessment with monitoring using both imaging and biomarkers can be personalized to the individual. So I can see a role here for MyoStrain from what I've heard. It seems to be a very sensitive technology to pick up early problems. And therefore, in addition to being involved in the baseline risk, it could potentially be also used as an imaging technology to monitor heart function during treatment. And if there's an early fall in the MyoStrain, that would be a red flag to the Cardio-Oncology team, not to stop treatment, but to consider whether we implement cardioprotection in order to keep people on these really important treatments. So my take-home messages from this symposium is that there is a potential application to use MyoStrain in cardio-oncology. Firstly, as part of the baseline cardiovascular risk assessment for patients before they start treatment, as a tool to use to monitor myocardial health during treatment as part of our surveillance programs, obviously the frequency personalized to the baseline risk. And there's a range of drugs and treatments for cancer we know can cause myocardial dysfunction, cardiotoxicity, and ultimately heart failure, such as anthracyclines, trastuzumab, proteasome inhibitors for multiple myeloma, and VEGF inhibitors, to name but a few, and where we've created these proformas. And so applying MyoStrain could be a new way to detect and then ultimately prevent cardiotoxicity. And finally, we have the cohort of individuals who are our cancer survivors who've had prior anthracycline chemotherapy, maybe in childhood or young adult life, where we should be reviewing and monitoring them. And I can see a role for MyoStrain, again, with its strong negative predictive value, a normal MyoStrain being an excellent result to show that the heart muscle is healthy. So thank you all for joining this symposium. Thank you for VCOS for hosting us. And if you have any questions, then please use the forms that were emailed to you as part of registration after you registered, and submit your questions, and we'll be happy to respond. And finally, thank you to Myocardial Solutions for supporting both the VCOS Summit and this symposium.